Welcome to the UT Healthy's Texas Virtual Education Series. Today's presentation topic is Common Pediatric Ear and Throat Disorders, featuring Dr. Robert Strominger, board-certified otolaryngologist at UT Healthy's Texas Ear, Nose, and Throat Center.
I've been asked today to talk about a couple of pediatric otolaryngology topics, specifically ear infections in children and tonsillitis in children, and how we treat them and what parents should be concerned about when their kids start having these problems, and what to expect when you're sent to see us in the office, and what we might want to hear to want to perform surgery on your child. So we'll start with the ear infections. And ear diseases in children are fairly common, specifically diseases in the middle ear. Otitis media, by definition, is middle ear, and inflammation within the inner ear. There are many reasons why kids tend to have more ear infections than adults, but it has a lot to do with the maturity of their bodies. The eustachian tubes themselves are more immature than in the adults. The eustachian tube is the drainage tube of the middle ear that goes from the ear to the back of the nose, and it's through this that the ear drains, and then infection can come up through and cause some problems in the kids. The immune system is immature. When kids are first born, they have some immunity from their mothers, transferred from the placenta. You have a lot of antibodies, and then especially if the child is breastfeeding, that gives immunity to the kids. But once they hit about 2 years of age or breastfeeding ends, their immune systems aren't mature yet, and they lose the immunity from the mothers. So it's after about the age of 2, 3, 4, in that range, where they have this transient drop in their immune systems and the ability to fight off infections. So they tend to get more infections. And then, of course, after that, they go to daycare and start getting the viruses and whatever spread around, and then school. So they're just exposed more to things to cause ear infections, and their immune systems aren't really adapted to be able to cope with them. And then big risk factors: parents who smoke. Exposure to secondhand smoke causes inflammation within the nose, back behind the nose where the eustachian tube drains, and they are going to have a lot more infections. And early on, daycare is a big risk factor for ear infections. And here is a slide showing the anatomy of the ear. And the eustachian tube, this drain that I talked about, has characteristics that are just not mature yet. It's more horizontal, and in the adults it's a more vertical tube, so fluids tend to drain out of it. The muscles that allow it to pump fluid out of it and keep infection from coming up, those muscles are not mature yet. They're offshoots from the palate, and just like they can't eat well and they can't pronounce words well or talk well, those are muscles that allow them to do those functions also allow the eustachian tube to function properly. And because they're not mature, it's not pumping, it's not draining properly. The other thing that you can see in kids is that if they have a big adenoid pad, we'll get to this a little bit later, but the adenoids are another tonsil in the back of the nose and the nasopharynx, right where the eustachian tube drains. So if that's causing some blockage, you're going to wind up with a eustachian tube that doesn't work. This will all lead to backing up of the fluids of the ear and predispose a child to more ear infections. The ear is the whole side of the head, comprising the mastoid bone. And when we look down the ear canal, we're seeing a very small piece of the ear through the eardrum into the middle ear space. And that's where otitis media occurs. But it's really occurring in the whole side of the head there through the mastoid. So if you have this drain that's not draining properly, and you have the mastoid, which is lined with mucosa, kind of like a honeycomb, and that does two things. It produces fluid, and it absorbs gases. So with a blocked drain, you wind up getting fluid trapped behind the eardrum, just like a blocked drain in a sink. And then with the mucosa absorbing some gases, it becomes a negative pressure. So you get this fluid trapped with a little vacuum that will suck stuff up from behind the nose and cause the recurring infections to occur. And so when we're looking at the function of the middle ear and the eardrum, we do what's called a tympanogram or tympanometry. And we can use this pressure test to look on whether the eardrum is moving or not. If the eardrum is moving normally, you'll have a type A wave, and we know that there's not fluid in the middle ear. The eardrum's moving well, there's no negative pressure. A type C tympanogram, which tells us there's negative pressure, meaning the pressure curve is on the negative side of normal. That's showing us that eustachian tube is not working. And that can lead to some otitis media. A little bit of fluid might be in the middle ear called otitis media with effusion. But if that eardrum's not working at all, and it's called a flat response or a type B, we know that there's lots of fluid in the middle ear. The eardrum's not working. It predisposes the child to some problems. And that's really what we're looking for when we're doing this test in the office, other than looking through the eardrum to see if there's some fluid. The concern with having otitis media with effusion is that it leads to conductive hearing loss. And with conductive hearing loss, you can have speech and language delay, depending on how long this occurs. And also having the fluid trapped in the middle ear, when you have the negative pressure and the kid gets a cold, that bacteria or virus gets sucked up into the middle ear space, and that's when you get the recurring infections. But really, it's a big concern with kids when their eardrums aren't working, there's fluid in the middle ear space, and they can't hear. And we can pick that up on hearing testing by comparing what's called the bone line, and that's when you tap the back of the ear, and that is testing the nerve directly versus air conduction. And that's when you put the headphones on or earplugs in, have a kid trying to respond to the stimulus. So if you have what's called an air-bone gap, that means that there's hearing loss. If that hearing loss is there for a prolonged period of time, a child might have some speech and language delay over that time period. There are different types of otitis media that we are concerned about. There's acute otitis media, and then, as I stated, otitis media with effusion, and that can be acute or chronic. And effusion just meaning that there's fluid behind the eardrum. It doesn't mean it's infected, where an acute otitis media is an infection behind the eardrum. And these are caused by common bacteria that we get. Everything from strep pneumonia, there's one called Murex allicaturalis, and Haemophilus influenza. We get vaccinated for some of these, but you can still have infections despite having these vaccinations. Kids with an acute otitis media, they'll have fever, they'll be in pain, they'll be pulling at their eardrums, crying, and if you take a look at the eardrum, it will be red, hot, injected, and you'll usually see the purulent white infection behind the eardrum. It will look like an abscess if you've ever seen that. You have to be a little careful, though, when you're looking in kids' ears, because kids that are crying really hard, their eardrums will turn beet red as well. So you really have to combine the symptoms with what you're seeing to really know that they're having an infection. And again, that's where the tympanogram comes in. If the tympanogram is normal, it's unlikely their ear is infected. So you combine all the data you have with your physical examination and the symptoms, and you can decide whether you have the infection or not. Some kids will get recurrent acute otitis media, or we'll call that chronic otitis media. And between these infections, oftentimes the ears can be perfectly normal. So they have an infection, they're treated with antibiotics or not, they come back a month later and the ears look great. Well, that's really good. That means that that eustachian tube at least is working. Now, if in between those infections you have fluid behind the eardrum, that's not so good because that child's more likely to have recurring infections. So it really depends on whether these infections completely clear or not. But what you have to understand is that in the normal situation, after an infection, a child could have effusion for up to 3 months, and that's perfectly normal, as long as they're not getting another infection, and it doesn't last longer than that, then hopefully it will clear over time. One thing I wanted to add that's kind of interesting is the different vaccines were introduced about 2000 for pneumococcus and Haemophilus influenza, but we're seeing less infections with the vaccinations that the kids are getting now, but kids that start having infections are more likely to need tubes placed because of them. Again, getting back to otitis media with effusion, it's again fluid occupying the middle ear space. It can be clear or serous, which is kind of a watery consistency, or it can be mucoid, what we call glue ear. Sometimes we don't know this until we put a tube in and suck some of it out. But a mucoid effusion is less likely to go away, and that child is more likely to need tubes. As I said, it can last up to 3 months after an acute infection, and this is perfectly normal. So if a child's not having recurring infections and their ears were good, they have an infection, and 2 weeks later they're still fluid, they don't need tubes. Or a month later, they don't need tubes. Or 2 months later, they don't necessarily need tubes. But if that effusion persists longer than 3 months, we call that chronic otitis media effusion, that's when we start becoming more concerned. We want to check the hearing. We want to check the tympanogram, make sure they're not having a conductive hearing loss that can lead to speech and language delay. And so it's somewhere between that 3-month period and that 6-month period when we want to place tubes, because we don't want the child to get speech and language delayed and not develop properly. Or if that effusion, that fluid is persisting and they're getting a recurring infection, that's when we might want to put tubes in. But it's really the persistent effusion that's the concern. A child having an infection, ears become perfectly normal, a month or 2 later get another infection, maybe a few months later get another infection. As long as their ears are normal between those infections, we might not necessarily want to put tubes in that child's ears because they're taking care of themselves. Putting tubes in may not stop infection completely. It changes it though. It allows you to treat it differently, and we'll get to that in just a little bit. So the real indication for tympanostomy tubes is if an effusion persists greater than 3 months with hearing loss. Potentially there might be some structural change to the tympanic membrane or middle ear that we might start seeing, maybe a scar tissue, the speech and language developmental delay, or if kids have other problems. Kids with Down syndrome or cleft palates are much more likely to have ear problems and need tubes. So we might be a little bit more aggressive in that patient population. The question came up whether adenoidectomy should be performed with tubes. Studies have shown that performing adenoidectomy with the first set of tubes is not necessarily beneficial. So by doing that, you're doing a lot of unnecessary surgery, unless there's another reason to take the adenoids out, like sleep apnea. But a child who comes back for a second set of tubes, that's when we'll recommend adenoidectomy being performed. Tubes are really quite simple to put in. It's a very safe operation as surgeries go. In an adult, we can do it in the office under local anesthesia, but in children, we do need to give some type of general anesthesia, but it's called gas mask anesthesia. They tend not to get IVs, they're not intubated. A mask is put over their mouth and nose, they breathe in the gas, they take a nap, And that gives me the ability to bring in a microscope and put the tubes in. You make a little 1 to 2 millimeter incision in the eardrum. You suction that effusion out. If it's gooier, it might be a little difficult, but we try to get it out. And we place the tubes. Their real name is pressure equalization tubes. We colloquially just call them ear tubes. But they relieve that negative pressure, allow the ear to drain, bypass the eustachian tube that's blocked up, allowing the ear to mature. There are different types. There's some beveled grommets that we tend to use that come out between 6 and 18 months. And then there are T-tubes that we tend to use on kids who need 2 or 3 sets of tubes, or potentially that Downs child. And they tend to stay in about 3 years or so, sometimes longer. But there's no permanent tube. The T-tubes are what people might refer to as semi-permanent tubes, but they all tend to come out in time. 1 to 3% of kids might develop a permanent perforation after the tubes come out. If that's the case, we do a simple patch to close that up. 15% of children need second sets of tubes. And as I stated previously, we'll perform the adenoidectomy with the second, maybe the third set of tubes, depending on how old they are. Obviously, the younger you are, where you need your first set of tubes, let's say 6 months, a year old, the more likely you might be to need that second set of tubes. If a child needs their first set of tubes at 3, 5, 7 years of age, chances are that's the only set of tubes they're going to need. The question also came in, do ear infections run in families? There are certain anatomical variations in human anatomy that might make that the case, but in general, that's really not an issue unless there's secondhand smoke. Secondhand smoke is really, really the biggest risk factor for families in terms of kids needing tubes. Allergy can also play a role because you can start with an allergic otitis media, leads to inflammation, leads to blockage of the eustachian tube, and then you develop the infection after that. But primarily, we tend to see it. A kid will get a cold, you get the swelling behind the nose, the eustachian tube blocks up, and then ultimately you wind up having to have tubes placed. But it's that otitis media with effusion with conductive hearing loss. It's asymptomatic. Kids don't necessarily know they're having hearing loss, and this is why your child will get hearing tested when they get to school. They start screening kids in schools at a very young age to pick up the child with an undiagnosed hearing loss. And when that happens, potentially it's a sensorineural loss or nerve loss that was missed. But most of the time, there's a effusion hiding there, and they need a set of tubes put in. So that's it for otitis media. And we're going to move on now to otitis externa and ear drainage, with the medical term for ear drainage, otorrhea. And that otorrhea and ear drainage can be with a child with a tube put in, or it can be from a swimmer's ear or otitis externa. Drainage out of the ear with tubes is perfectly normal. It's what you want, right? If your normal drain is blocked, you want the effusion or you want the infection to be able to drain out somewhere else. And by putting the tube in, it allows it to drain out the ear. What's interesting about it, once you get a swimmer's ear or you have drainage out of an ear because there's a tube in, the organisms change to Pseudomonas and Staph aureus. And the problem with that is there's no oral antibiotics that will treat this. The good news is that there's no role for oral antibiotics with swimmer's ear or a child with an ear tube with ear drainage. The topical drops work much better. They cover these organisms where there's no FDA-approved drug for children that does, oral drug for children that does. And so we're able to treat them more effectively and safely because we don't need to put the children on oral antibiotics. So if your child ever gets a swimmer's ear or they have tubes and drainage, just remember that the antibiotic ear drops that you'll be prescribed are really the way to go to treat these infections. We're going to move on to tonsils. This is probably the second most common problem that children have and the second most common reason why we operate on children. What are tonsils? Tonsils, the simplest way to think of tonsils is that they're external lymph nodes. They're lymph nodes that grow in the back of your throat, or lymphofollicular tissue. This was first described by Dr. Waldeyer, who was a German anatomist in the late 1800s into the early 1900s, that showed that we have tonsils that wrap the entire back of our throats. And so it got his name, called Waldeyer's ring. The big tonsils in the back of the throat that you see are called the palatine tonsils because they're by the palate. The adenoids, or the pharyngeal tonsils, or the tonsils that are straight back behind your nose. You can't see them when you look in the mouth, but those are the ones we talked about that might block the eustachian tube. And if I have to remove them, I have to use a mirror through the mouth so I can see them. There's the lingual tonsils on the base of your tongue. And if you get a good look at the back of your tongue, you'll see all these bumps there. And part of those are your lingual tonsils. And then if you look in the back of your throat, you'll see all these little bumps right on the back wall. That's posterior pharyngeal studding. And along the back, you might see some lateral bands along the sides. Those are tonsils as well. So when we talk about doing a tonsillectomy and adenoidectomy, we're not talking about removing all the tonsils. We're talking about removing or shrinking down the groups that tend to cause problems in humans. What do? Well, early on in infancy, they help the immune system develop, like the thymus gland, to T cell development. And then throughout all of life, they help sequester and fight infection. So they're there for a reason. But just remember, when we're doing surgery, we're not removing all of the tonsils from the back of the throat. Strep throat is the biggest concern, but many different things can cause tonsillitis. And the most common are virus infections, from influenza, different coronaviruses, not the one we're dealing with now, but children get coronaviruses, and that's why they seem to be doing better with this disease, because they have some immunity, because they've had a recent coronavirus. Adenovirus, Epstein-Barr virus, which causes mono, we'll talk about this, the different herpes simplex viruses, and then Coxsackie virus can cause a tonsillitis. So there are lots of things that, viruses that cause tonsillitis in children, and only 15 to 30% of tonsillitis is actually caused by bacteria. Group A, beta hemolytic strep is one of them, Staph aureus. There's chlamydia pneumonia, again, not the one chlamydia we're worried about, but a common organism that's in the back of our throat. But many different bacteria can cause infection in the back of the throat. The concern for strep is not what's happening in the throat. All tonsillitis resolves on its own, whether it's treated or not. So why are we most concerned with strep? Because it causes complications throughout the body. Scarlet fever, rheumatic fever, which is a heart valve and heart infection, pericarditis, the lining around the heart can get infected. There's kidney damage that can be caused by strep, called post-streptococcal glomerulonephritis. And there's something called PANDAS that we're seeing more and more of, which is pediatric autoimmune neuropsychiatric disorder associated with strep infection. And this is when a child with strep will look like they've developed ADHD or autism. And it's really unfortunate that an organism can cause this. And then juvenile psoriatic arthritis and psoriasis are all complications of strep. So that's the one we're most concerned about. That's the one we really want to treat if somebody gets an infection. We now have clinical guidelines for tonsillectomy for recurring infection. And it doesn't have to be strep. But again, strep's the one we're most concerned about. So if a child has 7 infections in 1 year, that's an indication to do a tonsillectomy. 5 infections a year in 2 consecutive years, 3 infections a year and 3 infections in years, or et cetera, et cetera. Recurring infections over years are an indication to do a tonsillectomy. And then there are other concurrent indications. They're big, they're missing school. So these are guidelines. They're not definitive recommendations that we need to follow. So it really depends on how the child's been doing, especially if they've had one of these complications occur during their infection. We tend to do more surgery for recurring infection in the older child population, the child who's made it to school. The younger the child is, the more likely we're going to perform tonsillectomy and adenoidectomy for obstructive sleep apnea, or because they're big, causing some type of obstructive symptom, like nasal obstruction. Again, adenoids contributing to the development of chronic otitis media, failure to thrive in the infant. If the tonsils and adenoids are too big, they can't breathe through their noses, they can't eat, they don't do well. ADHD from obstruction to developing obstructive sleep apnea, chronically sleep deprived, not getting enough sleep, they're starting to misbehave. Pediatricians are starting to think about putting them on ADHD medication. Perhaps they should have a tonsillectomy and adenoidectomy to see if they do better, sleep better, and then maybe don't have to be put on those medications. Children with asthma will do worse with big tonsils and adenoids. If you create obstruction here and resistance here, they have to breathe harder here so that their asthma will be much worse. Some children will start developing craniofacial growth abnormalities. If you have big tonsils and adenoids, the face might start growing out and lead to orthodontic problems. So orthodontists will sometimes send children in to have tonsillectomy and adenoidectomy before having braces put on them or considering other types of surgery. And then speech developmental abnormalities, inability to pronounce some words. If you can't get air out through the nose, you can't pronounce the words that require that. Another reason is development of tonsil stones. This tends to be in the teenager to young adult range, but sometimes younger. Tonsil calculi or tonsil stones form from the colonization of bacteria in the little crypts and the little holes that we see in the tonsils. And this stuff builds up and can fester and come out, and a lot of people don't like them, and they can cause bad breath. So it's, again, usually the older teenagers that we do surgery for this, but it can be the younger children as well. There are different techniques for tonsillectomy these days. When we're dealing with adenoidectomy, we really just shrink them down, either with electrocautery or something called coblation, which is a radio frequency device. It essentially vibrates so fast it melts what it touches. So again, we go in through the mouth, we look with a mirror, we have a curved wand that gets back there, and we just shrink them down. Tonsillectomy can be done differently. Historically, what we would do is some type of closed capsular dissection. Shuck them out, like shucking out a hard-boiled egg. But instead of a shell, it's the underlying muscle. And there's a little plane you can get in there and use cold steel, electrocautery, laser, coblation. It doesn't really matter. You shuck them out. These days, we're doing more and more what's called intracapsular tonsillotomy. And here at UT, we use a coblator to do that. What we do is we basically shrink the tonsils down. we get them nice and smooth so that we're not exposing the underlying muscle during the surgery. The benefit of that is that it's safer, there's a lower bleeding complication rate, and the healing process is much quicker. So the kids do better. They go back to school sooner. But the major risk of surgery is bleeding. It's low, but it's there. So as much as we can minimize it, we do. So primarily, we're doing an intracapsular tonsillotomy technique. Now, the one downside this, in a very, very small number of patients, you might need to go back and do an operation later if they start getting strep. But the immediate benefits of doing this safer operation outweigh that very small risk of having to do that. Mononucleosis, as we talked about, is one of the viral infections that we get. It's caused by Epstein-Barr virus. It's very common. It's ubiquitous in the population, spread very easily. Used to be called the kissing disease when I was young. I don't know if it still is or not. But it causes a really, really bad, painful infection, fatigue, enlarged lymph nodes, enlarged spleen, and can be very difficult for the kids to get through. It can take a good 3 months to recover, if not more, and you can be shedding virus for 9 months after infection, and that's why it's so easily spread amongst the school-age population. There is no role for surgery for this. It's one of these diseases that you just have to let run its course. But it can be very difficult for the kids to get through. Ultimately miss school and sports and such. And so how do we differentiate between viral and bacterial tonsillitis? We talked about the rapid strep test. That's similar to what's being done to see whether you have coronavirus. You put the swab in the back of the throat, rub the tonsil, put a little well, and it will show up whether somebody has strep or not. You can do a full culture and sensitivity to see what's growing back there. Sometimes we'll find a chronic colonizer that's causing problems, and that can lead to chronic sore throat infection, lead to surgery. Monospot for mononucleosis. There's the delay in that being positive from when the kids get mono. So sometimes the monospot will be negative, but the EBV titers, which is a blood test, will be positive. And they're acute and chronic antibodies to show whether they have an active infection or a late infection. And then an old-fashioned CBC is always good because you'll be able to differentiate depending on the shift, whether it's a left shift, which would make me think it's a bacterial infection, or elevated monocytes would make me think it's mononucleosis, or other lymphocytes would point to a viral infection. Thank you very much for being here.
We hope you enjoyed the presentation today. For more information about scheduling an appointment with Dr. Strominger, call 903-747-4098 or visit uthealthiestexasdoctors.com. Our next virtual seminar will be announced soon. Follow us on Facebook to stay up to date on upcoming events and seminars. Thank you for joining.